Video. I would like to thank the organizers for inviting me to present. I'm Fatema Ghasia, Associate Professor of Ophthalmology at Cleveland Clinic and Director of Vision Neurosciences and Oculomotility Lab at Kola Institute. And today I'm going to talk about fixation instability and amblyopia. I'll first briefly describe fixation eye movements and their functional significance, and then talk about the FEM abnormalities in amblyopic subjects and discuss the implications of FEM abnormalities on visual function deficits and treatment response. So a couple slides on some basic science. I can't advance my slides. Oh, here it is. Okay, let me try. Yeah. So visual system has a built-in paradox. We must fixate our gaze to inspect minute details of the world. However, if we fixate perfectly, the entire world would fade from view because of neural adaptation. So let's take an example here. If I have you look at a black cross, after a few seconds, the purple circles, they begin to fade from perception. If you move your eyes, those purple circles are visible. And this phenomena is called Trochlear Fading. It is an optical illusion that occurs when one fixates at a particular point for even a short period of time, an unchanging stimulus away from the fixation point begins to fade and disappear. Thus, during fixation, to thwart neural adaptation, when the highest acuity is achieved, our eyes are actually not completely motionless, but we make these small miniature eye movements, which are called fixational eye movements. So Martinez-Conde's lab, they did a very elegant experiment in which they recorded eye movements in subjects, normal subjects, when they were looking at the similar stimulus. They had the subjects push the button when they perceived the stimulus to disappear and release it when it reappears. And what they found is that microsaccades or fixational saccades, they increased during intensification and decreased during fading of the visual stimulus. So to just reiterate, fixation eye movements, they play an important role. They counteract visual fading by thwarting neural adaptation for both foveal and peripheral targets during prolonged fixation. So why are we interested in this? But before I go that, I just wanted to describe the features of fixation eye movements and show you a video of an eye tracker while we were measuring the eye movements. So notice that the pink and the green, which are the right and the left eye, when looking at a dot, they are not perfectly still, and we make these small eye movements, and that's what we are going to talk about today. So here's a sample of eye position traces obtained from a normal control. X-axis is time and y-axis is horizontal and vertical eye position of the right and the left eye. And normally we make these small fixational saccades indicated by these black arrows that alternate with periods of intersaccadic drifts. And typically we make about 1 to 2 per second of fixational saccades. They are binocular and they are conjugate movements. Now, frequently fixation eye movements are quantified using a measure called bivariate contour ellipse area. What this is basically when you plot horizontal and vertical eye position on X and Y axis, you get this cloud of fixation points. And so the more stable the fixation, the points are going to be tightly packed together. And when you fit an ellipse to this area, that area is the bivariate contour ellipse area. So the smaller the BCA value, the more stable is the fixation, and there is less fixation instability. Now, moving on to fixation instability in amblyopia, which has been reported by a number of labs. So amblyopia, as we all know, it's a neurodevelopmental disorder secondary to abnormal visual experience during early childhood. And what we did in our study is that we wanted to characterize what causes fixation instability in amblyopia, and then examine the effects of FEM abnormalities and how they correlate with visual function deficits seen in amblyopia. And finally, examine the link between FEM abnormalities and treatment outcomes. So we recorded horizontal and vertical eye positions from 115 amblyopic subjects when both eyes are viewing, when the fellow eye is viewing, and when the amblyopic eye is viewing. We use a remote video eye tracker, which has a very high sampling rate and spatial resolution, and the setup time is less than 2 minutes, making it ideal for recordings in children. And here's the distribution of the subjects. We had 1/3 controls, 1/3 were anisometropics, 1/3 were mixed with very few pure strabismics. And then when looking at severity, we had mild and moderate, and then some severe amblyopes. We divided amblyopic patients into 3 groups. The first group was amblyopic patients who did not have any nystagmus. So here again is a video recording, eye movement recording from a severe amblyopia patient. The green is the fellow eye and the magenta is the amblyopic eye. And notice when both eyes are viewing, you see this drift in the amblyopic eye. So when we look at the eye position traces obtained on the binocular fellow and amblyopic eye, the red trace here is the horizontal eye position of the amblyopic eye. Notice that there is that increase in the drift here. The drift is again evident during fellow eye viewing, and then when the amblyopic eye is viewing, in addition to the drift, there is an increase in the amplitude of the fixational saccades. So collectively, the increased amplitude of fixational saccades and the increase in the drift, they cause the fixation instability, as is evident in all three viewing conditions, including during binocular viewing, where the amblyopic eye is much unstable compared to the fellow eye. Now, we know that patients who have experienced disruption of binocularity in early infancy, they develop fusion maldevelopment nystagmus or latent nystagmus. So here's an example of a patient who had manifest latent nystagmus, because these recordings are obtained when both eyes are viewing and the nystagmus is evident. And when you look at the eye position traces, again, during binocular viewing, you see the nystagmus, there's a quick phase followed by a slow phase. This is when fellow eye is viewing, and this is when amblyopic eye is viewing. And the key feature here is that the direction of the nystagmus reverses from fellow versus the amblyopic eye. So when it's always beating temporally. The quick phases are always temporal, and this is like the telltale or signature hallmark that can be delineated very easily on eye movement recordings. And then, of course, in this patient, since they have nystagmus, there's an increase in the instability, which is particularly high during amblyopic eye viewing condition. Now, we found that there are patients with amblyopia who have nystagmus, but they don't fit the criteria of FMN. And these patients are different than those from congenital motor nystagmus, because they do not have the increasing velocity waveform that you see with congenital motor nystagmus. So here's an example of one such patient who had nystagmus, but did not meet the criteria of FMN. And this is what the eye movement traces show. So the nystagmus is most pronounced during amblyopia eye viewing. Notice that during fellow eye, there are some nystagmus beats, but you do not see the reversal in the direction of the quick phases like you see in FMN. And again, these patients have increased instability, which is particularly worse during amblyopic eye viewing. So when we look at the FEM waveforms across different types of amblyopia, what we see is that anisometropic amblyopes, they generally don't have nystagmus, or if they do have nystagmus, it's usually nystagmus without FMN. On the other hand, patients with strabismic amblyopia, they tend to have nystagmus compared to the anisometropic amblyopes. And then patients with mixed amblyopia, they were 1/3, 1/3, 1/3, where 1/3 did not have nystagmus, 1/3 had nystagmus without FMN, and then 1/3 had FMN. So the next thing I want to talk about is, why is it important to characterize this fixation stability? So recent research has suggested that amblyopia is not a simple monocular problem, but it affects both binocular and monocular functions of fellow and amblyopic eye. And our work has shown that the timing of amblyopia plays a role in the extent of visual function deficits seen in amblyopia. So with presence of FMN, there is greater impairment in binocular and some monocular visual function deficits of the fellow eye. So here I'm going to talk about contrast sensitivity measurements. We did contrast sensitivity measurements at low spatial frequency and at high spatial frequency. In low spatial frequencies, the bars are wider. In high spatial frequency, they're closer together, so it's a relatively hard task. And I'm going to show the data that we collected from the fellow eye, or the good eye, so to speak. And we divided the amblyopes into no nystagmus, nystagmus without FMN, and FMN. The black traces are at the low contrast, and the white traces here, bars, are the high contrast sensitivity. So in controls, the low spatial frequency contrast, the thresholds were better compared to the high spatial frequency, as you'd expect, because it's a more difficult task. Now, interestingly, the fellow eye of patients both with and without nystagmus, all three groups, they had the thresholds for the high spatial frequency, which were much worse compared to controls. In addition, patients with FMN Besides the height, the low spatial frequency was also affected. So this shows that the fellow eye of amblyopic patients, both with and without nystagmus, have abnormal contrast sensitivity. Patients with FMN have more deficits compared to the other two groups. Next, I'm going to switch gears and talk about FEM abnormalities and its link to patching treatment. So patching is the gold standard. And we know that despite good compliance, about 40% of patients, they have residual or recurrent amblyopia. Studies have shown that if there are certain predictors that can predict patching treatment response, including if you were diagnosed at a later age or you have more severe amblyopia, you're more likely to have residual or recurrence of amblyopia. But besides that, what we wondered is that can FEM abnormalities be linked to treatment outcomes for patching treatment? So we know we've seen previously that during amblyopic eye viewing, the FMN can get worse. So here's a plot showing the amplitude and velocity. The red traces are when during monocular viewing, and the black traces are in binocular viewing. And notice that the amplitude and the velocity, they're shifted to the right, so they have greater amplitudes and velocities in monocular viewing. And so our question was, does the presence of FMN determine treatment response? In other words, patients who don't have nystagmus, do they respond better, do have greater and quicker response to part-time patching than those without FMN? So to answer this, we recruited 53 amblyopic patients. We measured their fixation eye movements, and 21 had no nystagmus, 21 had nystagmus without FMN, and 11 had FMN. The age at treatment, they were all about 6 years of age. The severity, 3 had mild, 35 had moderate, and 15 had severe amblyopia. And then we had 19 anisotropes, mixed were 28, and strabismic were 6. And we looked at 3 outcome measures. These were assessed after visual acuity had stabilized with no further improvement or deterioration at 2 consecutive visits, at least 6 weeks apart. And we looked for the amount of visual acuity improvement, stereopsis at the end of treatment, and the total duration of treatment. So first, I'll describe these outcomes as a function of type of amblyopia, clinical type of amblyopia. So here's the visual acuity improvement and patching duration. The patching duration was pretty similar, maybe slightly higher for the strabismic, and perhaps there was some suggestion that mixed amblyopes tend to do a little worse compared to the other 2 groups, but none of this reached statistical significance. Now, when we looked at these outcomes as a function of fixation eye movements, it was pretty clear that patients with FMN, they required longer durations of treatment. Also, the extent of visual acuity improvement was less in patients with FMN compared to those without nystagmus, but it did not reach statistical significance. So the other thing that we looked at is the final stereopsis at the end of treatment. So for the type of amblyopia, anisotropes tend to have better recovery of stereopsis compared to the other 2 groups, as well as patients who have FMN, they really did not have much improvement in stereopsis. So we have converted these values in log arc seconds, and if they didn't get the fly on the titmus, we assigned them a value of 3.2 log, and you can see basically most of the patients with FMN, they did not have any improvement in stereopsis despite showing improvements in visual acuity. Next, I want to switch gears and talk about how FEM abnormalities can be useful to understand dichoptic treatment response. So there's data suggesting that dichoptic treatments are non-inferior to patching treatment. However, randomized controlled trial have shown a mixed result. PDIC did a big study, and there are some other studies out there where they have found that there are patients who, after dichoptic treatment, don't have improvement, as good of an improvement in visual acuity. And so we wondered whether eye movements can help us understand the treatment response. And so what we did is we again measured fixation eye movements, but this time, rather than just looking at a dot, this was a dichoptic stimulus. So each eye was presented a different contrast, if you will. The fellow eye, the contrast was varied at 100%, 50%, 25, and 10%. And the amblyopic eye, the contrast was kept constant at 100%. And we measured their eye movements using the eye tracker. What we find is that patients, this is an example from an anisometropic patient with amblyopia, and the blue traces the fellow eye and the red traces the amblyopic eye. Notice that even at 100% contrast, the amblyopic eye is pretty unstable. But then as you lower the contrast of the fellow eye, the instability tends to increase, even in the fellow eye. So perhaps the increase in instability would make it hard for that eye to attend to the images that are being presented and perhaps contribute to less treatment response. We also saw that patients who had strabismus, here again, we plot the strabismus angle, and here's a histogram. The cooler colors are at the higher contrast to the fellow eye, and the darker, and the yellow and the red is when the low contrast is shown to the fellow eye. The strabismus angle gets worse. So again, if a patient is looking and doing the treatment, if the eye is more deviated, the amblyopic eye, then it's less likely that there would be treatment response. So with that, I would like to conclude that amblyopic patients, both with and without nystagmus, have increased fixation instability. FEM abnormalities correlate with binocular and monocular visual function deficits. Patients who have FMN require longer durations of part-time treatment, patching treatment. Despite modest improvement in acuity, stereo recovery is poor in amblyopic patients who with FMN that are treated with part-time patching, and perhaps fixation instability and strabismus angle changes in the dioptric environment, particularly low fellow eye contrast, could be responsible for having mixed results with dioptric treatment. I'd like to thank the funding agencies and the lab members that help us put this work together, and I'll take any questions.